Getz Pharma is establishing the largest pharmaceutical plant to be constructed in South Asia at one site to cater to the ever-growing health needs of the region.
Our values are very simple. We'll have respect for people, our employees, our suppliers. They form the basis of our quality. Our people are very passionate. Passion is within our DNA. Passion to excel, passion to perform, passion to work together, and passion to enjoy while we are working together.
A business is about meaning, about values, a mission, a vision, enriching lives through innovations in healthcare. Every day, Getz Pharma begins with this vision. And every day is a new opportunity to impact thousands of lives. Getz Pharma has a very simple philosophy. We help people live healthier lives. Getz Pharma's mission is to develop, produce, and market safe, effective and quality medicines and healthcare products that improve the health and quality of life for men, women and children. One of the top 3 pharmaceutical corporations in Pakistan, and among the fastest growing pharmaceutical in every country it operates in, we have touched the lives of millions of people. Through our journey, we have achieved extraordinary milestones because we have always put people first. We challenge ourselves, challenge the entire industry, and challenge the way people see problems related to healthcare. And we are nowhere close to being done. Our team of over 5,700 people drives this very change in over 22 countries around the world. Every single day, we develop over 542 pharmaceutical brands that cover a wide array of ailments in the spheres of hepatology, gastroenterology, cardiovascular, pulmonary, rheumatology, and infectious diseases. Behind this success is our organization's DNA, which is built around our strong employees. We invest in our employees' dreams that grow on to become their abilities. These are the hardworking men and women of Getz Pharma who have proven their passion and promise to developing the highest standard of pharmaceutical products. Getz Pharma promotes synergy of active talent at work, which results in a single-minded commitment to produce extraordinary results and achieve the highest standards of quality in all spheres. Our unique people and process paradigm helps achieve the twin objectives of emphasis on regulatory compliance and quality on one hand, while fostering innovation and creativity on the other. We believe in constant and periodical learning. As a constantly growing pharmaceutical company, we dedicate our time to contribute towards greater economic, social, and environmental goals. We develop safe, effective, and affordable medicines so the whole world can have access to life-saving drugs. Through our success, we have stayed true to the values that lie at the heart of our business, deeply influencing our research, products, and relationships with our partners. Getz Pharma, being the single largest exporter of pharmaceuticals from Pakistan, addresses differentiated and unmet healthcare needs through our new drug development initiatives. Getz Pharma, safety is part of the corporate culture, and we embrace safety in all aspects, including infrastructural, employee, environmental, and community safety. The Getz Pharma Quality Control Laboratory, the only one in Pakistan and third in the region, has been pre-qualified, accredited and validated by the World Health Organization. Getz Pharma believes that a business is a potent social force by itself and is uniquely empowered to make a difference in people's lives. That's why our vision doesn't stop here. Getz Pharma is establishing the largest pharmaceutical plant to be constructed in South Asia at one site to cater to the ever-growing health needs of the region.
Our values are very simple. We'll have respect for people. Our employees, our suppliers, they form the basis of our quality. Our people are very passionate. Passion is within our DNA. Passion to excel, passion to perform, passion to work together, and passion to enjoy while we are working together.
A business is about meaning, about values, a mission, a vision, enriching lives through innovations in healthcare. Every day, Getz Pharma begins with this vision, and every day is a new opportunity to impact thousands of lives. Getz Pharma has a very simple for men, women, and children. One of the top 3 pharmaceutical.
Good afternoon, everybody. Good afternoon, ladies and gentlemen. Good afternoon, ladies and gentlemen. Afolabi Babajide. I'm a product manager with Getz Pharma. It's an honor to have each and every one of us here this afternoon. Start by saying Happy New Month. We're in the second half of the year, and also this week happens to be the World Allergy Week. Over the next 90 minutes, we'll be having distinguished speakers, moderators, and personalities in the healthcare sector discuss with us allergy manifestations and clinical management during a pandemic. As we all know, COVID-19 is the new normal. But before I go further, I would like to share one or two statements. So as we all know, this is the second series for Getz Pharma in our series called Getz Velocity. So we have the local and international webinars. This is the second in the local Velocity series. The last was done last week, Wednesday, and it was focused on the role of primary care providers in the management of overactive bladder. And we had Dr. Tijani as a urologist who was able to engage us, and we also had the family physician and geriatrician talk to us about the roles we play in management of this condition. So today we'll be looking from the angle of a dermatologist perspective and also an ENT physician perspective in management of allergy manifestation and clinical management during this period of COVID-19. So without taking much of our time, I would like to welcome us once again, and the next thing is I'll be introducing our moderator for today's webinar. So I'd just like to share his profile before I go on to bring him on.
I'm sorry, we lost Afolabi Babajide. He will join us almost immediately.
Okay, apologies for the break in transmission. So as I was saying, so I will be introducing I'll be introducing our moderator for this evening. So he's a professor of otorhinolaryngology, head and neck surgery, and consultant otorhinolaryngologist from the College of Medicine, University of Lagos, and also practices at Lagos University Teaching Hospital in Lagos. He earned his MBBS degree from the University of Ibadan in 1983, and he has won laurels for the university at intermedical school quiz and debating competitions. He is a fellow of the West Africa College of Surgeons and National Postgraduate Medical College of Nigeria. He is a recipient of the Garnet, Passy, and Rodney Williams Scholarship in Australia, and he was promoted to the rank of senior lecturer in 1998. He was appointed associate professor in 2003 and became a full professor of otorhinolaryngology, head and neck surgery in 2009. He is an active member of many learned national and international associations, including the Otorhinolaryngological Society of Nigeria, which is ORLSON. He's also a member of the Pan-African Federation of the Otorhinolaryngological Societies, PAFOS, also a member of the Nigerian Surgical Research Society, and a member of the International Federation of Otorhinolaryngology Society. He's a member of the European Academy of Allergy and Clinical Immunology, and he has served in the University of Lagos through teaching and training of over 3,000 undergraduate medical and dental students in the College of Medicine from 1993 to date. in various capacities within the college. He has also served in other institutions of higher learning in various capacities, such as examiner to the National Postgraduate College of Nigeria and external examiner in International Postgraduate Medical College, such as the West African College of Surgeons and College of Surgeons of East, Central, and Southern Africa, among others. He has also attended over 34 scientific conferences. He has presented in over 30 scientific conference papers, nationally and internationally, and he has delivered as guest speaker in 8 lectures. He has published over 80 scientific articles in learned journals to date, and he has published 1 and contributed chapters in a lot of textbooks. He is also successful as supervisor for over 30 postgraduate fellowship dissertations and participated in training of over 60 otorhinolaryngologists in Nigeria. I would like for us, even from our different centers, to give a round of applause as I welcome on board Professor Clement Chukwuemeka Nwanwolo. Professor Clement, you have the floor, sir.
Thank you very much. Good afternoon, distinguished ladies and gentlemen. First of all, I'd like to welcome you all to this webinar presentation that is put together by by Getz Pharma and by Getz Pharma. Okay. By Getz Pharma and the Otorhinolaryngological Society of Nigeria as part of the celebrations of the World Allergy Week. We all know that every year the World Allergy Organization under the World Health Organization normally chooses a theme for the World Allergy Week. The one for 2019 was the global problem of food allergy. This year, 2020, the world has witnessed a pandemic, and so the topic for this year it's the world has chosen to talk about allergy and COVID-19, bearing in mind that the symptoms of allergy are always present either perennially or seasonally, whether COVID-19 exists or not. But now that we have COVID-19, more importantly, it becomes more topical for us to discuss how do we continue to manage our allergy patients during this pandemic. And this is the bane of the discussion today. The World Allergy Week has chosen the title, Allergy Care Does Not Stop with COVID-19. And so in this webinar, we are going to discuss the allergy manifestations and clinical management of allergy during a pandemic. And with us today, we have very distinguished speakers who are quite experienced to discuss this topic. And we shall also take remarks from the audience, those who are listening to us. So I'd like to welcome everybody, and more particularly welcome the speakers and the organizers. And at the appropriate time, I shall introduce the speakers. Thank you. Okay. Now, the president of the Otorhinolaryngological Society of Nigeria is with us, and I would like to introduce him so that he will give us some opening remarks before we start off. We have, it's my pleasure and singular honor to invite Professor A.D. Salisu. Professor Salisu.
Thank you very much, sir, and good afternoon, distinguished ladies and gentlemen. I bring you salutations from Kano, and I would like to welcome everyone to this webinar. I would like to thank all of you for being here, and particularly
Okay, I think we have some audio challenge from the president of Otorhinolaryngological Society of Nigeria. Professor Salisu, we can't hear you for now. Can you hear us? Okay, I think there were some network issues. Maybe in order not to waste time, I will just go on to introduce the first speaker. That is Dr. Erere Otofranowe. Yes. Dr. Erere is a consultant physician, dermatologist, and genitourinary specialist. She is a lecturer with the College of Medicine, University of Lagos, and an honorary consultant to the Lagos University Teaching Hospital. Dr. Erere is a clinical researcher who has authored and co-authored several scientific papers which are published in peer-reviewed journals, both locally and internationally. She is a regular speaker at professional and non-professional conferences and seminars. She is a fellow and member of many local and international professional societies, including the Nigerian Association of Dermatologists, the International Society of Dermatology, and the American Association of Dermatology. She is currently an active frontline physician managing COVID-19 in Lagos, Nigeria. Please join me in welcoming our very amiable, brilliant, and very intelligent Dr. Erere Otofranowe. Okay. Okay, I think Professor Salisu is back now. So let us take Professor Salisu's introductory remarks before Dr. Erere goes on to speak. Professor Salisu.
Thank you very much, sir. We seem to be having some network issues on this end. Now, one of our speakers today is a very senior ORLSON member, and he is also the editor of our journal, and is an accomplished academician. He is the current faculty chairman of National Postgraduate Medical College of Nigeria. He is an eloquent speak when listening to Professor Ologe. His lecture today during this interesting. Can you hear me?
Yes, we can hear you. We can hear you.
All right. His lecture today promises to be a very interesting and educative one. He'll be speaking on a very important subject. As practicing otorhinolaryngologists and as clinicians, we are aware that you cannot complete without examining the nose and throat. We are also aware that during this pandemic, the ENT surgeons are one of the highest risk personnel when it comes to this assessment. So I believe Professor Ologe's lecture today will help us navigate this issue of having to care for this patient with allergic rhinitis. So let us all sit back, participate actively, and translate what we gain from this session into better quality practice. I would like to thank once again the organizers. I would like to thank once again the organizers. Getz Pharma. Apparently, the reality of this session flags up an important and interesting relationship between ORLSON and Getz Pharma. So once again, I implore all of us to sit back, listen.
Okay. All right. Thank you very much. We will now take the lecture by Dr. Erere, who will be looking at the dermatological perspectives of allergy manifestations in the COVID-19 pandemic and the clinical management. So please join me in welcoming Dr. Erere, consultant, dermatologist, and genitourinary specialist. You're welcome, Dr. Erere.
Mute. Thank you very much. Can you all hear me? Okay, that's my video isn't on. I guess that doesn't matter. Okay, right. Good afternoon, everybody. I'm in the midst of eminent professor of yourself. Thank you for the introduction. So without wasting much time, I'm just going to focus on the task ahead of me by ORLSON and Getz Pharma, this collabo. So for clinical management during the pandemic, my task, the learning objective is to help primary care practitioners, PCP for short, understand clinical manifestations of idiopathic urticaria. I'm also expected to highlight recent updates in clinical management. And I'm hoping that at the end of it all, we may be able to see a link. What's the role between skin allergy and COVID-19, and what role primary care physicians will play. Hopefully you know what it means to be allergic. Assuming that we have people who already know such things. But before we go further, let's just quickly define who a primary care practitioner is. One would easily say licensed healthcare personnel who medical care. And this will be ordinarily the family physician, the general practitioner, maybe a pediatrician or an OBGYN, even an internal medical care practitioner. Internal physician assistants who are considered primary care practitioners. I mean, would we say they are? Considering that patients get see them probably before they come to the doctor, yes, I would say that we can. I suspect your neighbor, Mama Lagbaja or Papa Lagbaja, or a family friend, or a mother or a mother-in-law. We need to be careful about that. Or like our slightly more learned population, or even the populace now, Dr. Google. They go to Dr. Google before they come to you. So we need to be careful. But can we define terms quickly? We talk about allergy and hypersensitivity. And one would say that an allergic reaction is hypersensitivity to a usually harmless substance called an allergen. And this can come by virtue come into the body either by swallowed. And these are the common things that we do. Animal dander, as the case may be, some medications, some foods, these things I think people generally will know, but then pollen and dust and mildew and mold are generally considered to be the more common allergens. So the allergy refers to certain diseases in which immunological response to common environmental antigens will cause tissue inflammation with all the cytokines and all the things that come, and then organ dysfunction. And we will say hypersensitivity is synonymous for sensitivity. They talk about it. My head. Okay, sorry. I gather you can barely hear me. I'm trying to increase my mouthpiece. Is this better? Moderator, is this better?
Yes, ma'am. Yes, ma'am.
Yeah, much better.
All right, thank you. Apologies. I hope you've heard a few things I've said before. Okay, so just going on. So an allergen will be any antigen that causes allergy. Antigen is the foreign thing, and the allergen is either inhaled or ingested, like I previously said, and is processed by special cells called dendritic cells. They are antigen-presenting cells. So these literally go and come cap in hand to the cells that will now process those antigens and cause the inflammatory response that we want to talk about. These allergens may be complete protein antigens, as we see in pollen and animal dander, or haptens, which are low molecular E-response, which is the antibody that starts the whole drama. Ability to actually react or respond immunologically to these commonly natural allergens is called atopy, because it's you have the idea to respond with continuous production of immunoglobulin antibodies. So with having said all of that, would we say urticaria is an allergy? What is urticaria? It's defined by Zuberbia. Zuberbia is one of the more learned professors in the field of allergology. They've defined urticaria as a heterogeneous skin disorder that may be acute or chronic, and defined particularly by the appearance of wheals, commonly called hives, and so the presence of this transients, which is the fleeting, they're here now and while the evanescent swellings, all the symptoms and signs that are irritation temporarily, we're talking acute or chronic with 6 weeks interval. So if you have urticaria that lasts more than 6 weeks, we're talking chronic urticaria, not necessarily idiopathic yet. So what are the manifestations? What would you commonly see as urticaria? A wheal in patients with urticaria has 3 typical features. The central swelling of variable size, so asymmetric to a large extent. Almost invariably you can see it. And itching is common, but transient, it doesn't stay long. The skin returns to normal appearance within 30 minutes to 24 hours, usually not more than 1 day you have the wheal. And this, I don't know if you can appreciate the picture that we were seeing. There's this redness and swelling in this picture. I give you some. So it might not be appreciable if you don't go looking for it. This looks like almost like a cellulite you see skin. But that's, you need to really look closely. So these are all in urticaria patients is characterized by the sudden pronounced skin colored swelling of the lower subcutaneous or mucous membrane. So usually the lips, the rather than an itch compared with urticaria. And it resolves a lot slower than urticaria. So sometimes it can take up to 72 hours to resolve. So if we have those at the back of our minds, look at angioedema, and this is a picture of this. You can see the lips and even the swell. Apologies, I seem to have had issues with network. I hope I'm back on.
Yes.
All
yes,
right.
you are back.
Okay, so I had gone through manifestations of urticaria. Can you see my screen? Can you see the screen?
No, yes, Dr.
Okay, just a minute. Slide share. So they need to put me back on slide share.
I can only see you, ma'am. The screen is not there.
It's not on. Hold on. You have to make me slide share again. I'm not able to do it. Okay. Hang on. Oops. All right. Network issues, apologies, COVID problems. Okay. Are we okay?
Yeah.
Mr. Kennedy, are we okay?
Yes, Dr. Erere, we are fine. Right. Thank you.
Okay, so thank you. So I talked about acute urticarias generally, and that's what we just talked about. But now, chronic urticarias, we talk about presence of the recurrent and angioedema for a period of 6 weeks or longer, like I said before. It is usually called, in fact, that's the preferred term by the 2018 guidelines, the factor, and it excludes all the producible urticaria. Apologies. So they say, what's going on? Audio isn't clear.
No, it's not from the network.
Wow.
Can we connect it to the network?
Okay. Apologies. The moderator has asked me to connect to another network. So just give us a minute. This is ridiculous.
Yeah, it's okay. Yes. Hello, distinguished ladies and gentlemen. I think we are having some challenges with the network for Dr. Erere. That is being handled now, and it will soon be corrected. But while that is going on, she's back now. Okay. Okay, but while it's going on, I think before she comes fully back, I would like you to please note your comments and questions in writing so that during the period of question and answer and commentary, we'll be able to take them. You will send the questions by chat to me, and then we'll pick them and call on whoever to either make comments or ask the questions. So please, we want it to be as interactive as possible, and so please try and listen and be attentive. Thank you. I think I'd like to welcome Dr. Erere back. Thank you very much.
Thank you very much, Prof. Apologies again. Network, we can't help it. Okay, so as I was talking about chronic urticarias and being combination of chronic spontaneous urticaria, CSU, and CINDU, which is chronic inducible urticaria. So generally, at least in Luz, this was a study that we did in Luz a couple of years ago, myself and two of my colleagues, Akinkuku and Ayalo. About 2% of hospital frequency of patients had urticaria, with almost 72% of them having chronic urticaria. So it is quite a significant thing. In the US, it is estimated about 15 to 23% of their population will experience both either acute or chronic at a lifetime. So that's a 0.5% lifetime prevalence of chronic spontaneous urticaria in the environment, general population, with females generally having a bit more, twice as more affected as males, and adults more commonly than children. In about 50 to 90% of cases, urticaria is associated with angioedema, and it is a debilitating disease with a high socioeconomic burden and a negative impact on the quality of life of members, because the patients themselves and their family members. Sometimes, you are scratching, you're ashamed, you are hiding to scratch, you're in a meeting, you're uncomfortable. Sometimes when you scratch uncontrollably, you have escoriation marks, which looks bad, and it will heal with post-inflammatory hyperpigmentation, which of course you now want to try to correct. So the cosmesis in that is also a problem. And I mean, generally, the natural history of chronic spontaneous urticaria in adults indicates that it is usually self-limited, between 2 to 5 years. But look at the figures, 50% of them should undergo resolution in about 6 months or more, and about 20% experience resolution between 3 and 5 years. But funny enough, about 50% of them will still relapse. And the irony is that the natural history, this natural history I've just said, is not influenced by treatment. So you sometimes wonder, do I want to bother doing this or not? Of course you want to bother, because it is very uncomfortable. They are scratching, their QOL is really, really bad, and that's important. So just quickly to talk about the classification of urticaria, so that we have a fair idea of why we need to treat it sometimes. Histaminogenic urticaria or non-histaminogenic urticaria, meaning that which of them would do well with probably antihistamines, which is one of the mainstays of treatment. So we'll talk about classifying urticaria based on whether histamine is being released, and the patients usually will respond to physical stimuli. What particularly happens is that their wheels are asymmetric in distribution. Transient angioedema, yes, compared to the non-histamigenic ones, where bradykinin and interleukin and cryopyrines are associated. They usually are symmetrical. So you say that the non-histaminogenic urticarias are more systemic, they'll have a bit more systemic and autoimmune related, as opposed to, so autoantibodies, as opposed to the histaminogenic ones. And if you think about that classification, you can see the temporal thing with terms of chronic urticarias, where the wheals will persist for relapsing for about 6 weeks or more. So this is a paper by Houston and Sabatu. It's quite recent, and they've done very good in classifying. So you know which one you should bother using certain medications for, and which one you shouldn't bother. Now, quickly, recommending diagnostic tests in frequency of urticaria. In this position paper by the European Asthma and Allergology and Clinical Immunology, EACI, EDF, that's European Dermatology Forum, and the World Allergy Organization, they gave the guidelines to define and diagnose and classify urticaria through management. I just want to highlight that of CSU, that's chronic spontaneous urticaria, which is the idiopathic urticaria. That the routine diagnostic test, yes, you might do differential full blood counts and all of that. You may see some eosinophilia, you may see some basopenia, ironically, and ESR elevated or not in CRP. What the 10 days is that as much as possible, but in no particular preferred order, after you have taken a very good history, looking for suspected triggers and possibly avoiding them, especially like medication, you should try to at least conduct tests for H. pylori, Helicobacter pylori, an infectious disease, and it has been associated with urticaria and thyroid hormones, particularly. I know in my center, we definitely do stool for H. pylori antigens, and we check for thyroid hormone antibodies, also antibodies. Skin test, neither here nor there, because you have to do quite a number of things before you get to that point, and you have to interpret your skin test, so you don't spend patients' money unnecessarily. It gets to time. Biopsy indicated, possibly or not, depending on a particular case. And these are the different physical urticarias: cold, heat, solar. This is what triggers people that have more often acute urticarias. So how do we manage these patients? According to this multiple association, I mean, they all came together, all the different European associations, GALE, which is the Global Allergy and Asthma European Network. Everybody decided that the best way to treat is to treat the disease until it's gone. Now, bear in mind that we had said this disease have a natural history and sometimes they will go, but you want to make patients feel better. And the therapeutic approach to chronic urticaria: identify and eliminate underlying causes if you can find them. Is idiopathic when you can't find them. Avoid whatever it is that's likely eliciting the trigger. And sometimes introduce tolerance. So expose the patients gradually to the trigger that you think you found. And of course, pharmacological treatment to prevent the mast cell mediator release. Now, treatment should follow the basic principles of treating as much as needed, but as little as possible. You don't want to go too much. And this may mean that you may step up or step down treatments in the algorithm, which I'm following up with now. And you can see first up is the use of second generation antihistamine, SGAH. Within a month, if the symptoms are intolerable, you can increase the dose for up to 4 times. If the symptoms are inadequate, you may now add the human recombinant monoclonal antibody, omalizumab, because you want to try and take care of the autoantibodies that are there, or cyclosporine. Now, this is according to these guidelines. The Americans are slightly different from the Europeans and the International Society. But here you can see that when do you refer to a specialist? By the time you are increasing second generation antihistamines up to 4 times a day, you should send them to a specialist for more. And these are the examples of the second generation antihistamines that we have. In our environment, I've highlighted 3 particularly. These are the things where we more commonly see: cetirizine, fexofenadine, and levocetirizine. Desloratadine is seen, but not as frequently as the others. So let's compare the international and the US guidelines. What is very, very key? The difference is they both agree with monotherapy with second generation antihistamines. But here, in the Americans say you can, after advancing for those, add another SG second generation antihistamines. They also say you may add cimetidine or ranitidine, the H2 antagonist, or the leukotriene antagonist. And also they say that you can actually add first generation antihistamines to be taken at bedtime, because of course this is sedative to a large extent, before you move on to these older ones that still do their work, hydroxyzipine and doxepin, before the biologics. If you notice, not any of them, actually, you can see that there is no point about corticosteroids. We're talking about chronic urticaria. However, there is a comment here that says a short course of corticosteroids may be considered in cases of severe exacerbations. So this is a patient that has chronic urticaria, or sometimes they have a flare. At that point, you may use a short course of corticosteroids, but it is not one of the recommended things, so we need to be very careful. So what do they agree? Because these are obviously differing. I just brought out these 2. They both agree. Consensus, over 90% of them agreed that yes, second generation antihistamines should be first line. So no more using first generation as first line. It's evidence-based and consensus-based. And then they also said they didn't agree to use different antihistamines. In fact, they recommend against it, that there is no point doing 2 antihistamines, H1 antihistamine at the same time. Use 1 to its maximum, which is up to 4 times a day. People commonly will just give maybe once a day and say, oh, you tried that. You can actually increase it. So quickly, before I leave, skin allergy and COVID-19 link. So I just want to illustrate this with the telemedicine case. One of my colleagues sent to me, and I'm just putting the WhatsApp Snapchat. So you see, that's what's happening. A lot of people are doing virtual telemedicine, virtual dermatology, virtual whatever it is right now. And so he sent this case to me. This patient had sent him cases, symptoms. And look at this, my nose is constantly blocked. I'm full of phlegm. I have tons of allergies, including food allergy. I have hives, difficulty in breathing. They keep me up at night. 3 weeks ago, I had a reaction. 3 days ago, I had another one. And this is within the last 2 to 3 days. So we're talking this month. Post production and dryness, but heaviness in my chest. Now, I don't know about you, but in Nigeria now, all these symptoms, if you see them, they will say COVID. Everybody will say this is COVID, forgetting that this patient has given you a lot of information that there is a history of atopy. So the patient is highly atopic. And somebody asked the person to quickly go do a skin allergy test without actually doing much more. All right. Now, what's the link? We know that atopy, whether it's atopic dermatitis, allergic rhinitis, vernal conjunctivitis, asthma, or food allergy, may arise with any trigger at all. And it's not the sites of entry that will be the manifestations. And what are we doing right now? We're telling everybody, recurrent hand washing, use sanitizers, use dilute household bleach, do this. And there is a change in weather. We've entered the rains. Any of these can actually trigger a flare of atopic dermatitis, allergic rhinitis, or any of the other. So what are we doing? We're in an environment where allergy is actually prone. For these patients, because of the symptoms, they are afraid to go to the hospital. So there's reduced hospital visitation because the patient is afraid of the doctor is afraid of the patient. The hospital pariah syndrome, as I call it. And we don't have enough health insurance. We don't do telemedicine so well. We're trying, we're getting better, but there is that. And is urticaria there as a manifestation of COVID or not? Publications from Italy and Spain have suggested that yes, urticaria may be one of the manifestations of COVID-19. But that doesn't mean that you will forget that the patient may have primary allergy. And when do you do a skin allergy test? As a primary practitioner, if you're not too certain, please refer to the specialist. So in concluding, I just want to say that, I mean, I'm not supposed to be making allegologists of everybody here, but if we remember that allergy care does not stop with COVID-19, as per the theme of World Allergy Organization. It's important, imperative, in fact, that as primary care physicians, you have to counsel. Your education and your counseling is aimed at looking for other atopic manifestations. You need to look for the likely triggers and ask the patient to avoid. They can send you patients' photos. They can tell you this was how I was and this is how I am now. You can find out more about it. And then prescribing and dispensing antihistamines appropriately. Website, Nigerian Association of Dermatologists, for more information. Thank you very much for listening to me. I hope I've made some difference. Right.
Thank you, Dr. Erere, for that very lucid presentation. Very straight to the point, though quite a bit technical, but I think a lot of the people in the audience are noting down their comments, and we'll take that later during the question and answer session. Now, I think it's time for us to go on to the next topic, which is the ear, nose, and throat perspective, and that will be delivered by our very able speaker, Professor Folu Shayo Emmanuel Ologe. Professor Ologe is a professor of otorhinolaryngology, head and neck surgery, University of Ilorin, an honorary consultant to the University of Ilorin Teaching Hospital. Professor Ologe has 33 years clinical experience working in various capacities from the period when he had his MBBS in 1987. He is a fellow of the West African College of Surgeons and the National Postgraduate College of Nigeria. He has over 80 publications and a textbook, and is an examiner in both of the to international and has attended over 40 national and international conferences. He's very rich in pathology, audiology, and endorsed general otorhinolaryngology. It is my pleasure to welcome Professor Folu Ologe. You are welcome to tell us about the clinical manifestations for allergic rhinitis in a pandemic.
Thank you very much, sir. I am presenting allergic rhinitis. Okay, I'm presenting allergic rhinitis, and I thank Dr. Erere for his very wonderful presentation. I must say that some of my illustrations are taken from Google Images. We have already mentioned our target audience. The learning objectives, we like to understand that allergy care does not stop in a pandemic. So just as there is a pandemic, other diseases subsist and they must be treated. We also want to understand the etiology and pathogenesis of allergic rhinitis. We like to reevaluate the diagnosis and treatment of allergic rhinitis. And then we'll try to see how we can identify cost-effective management options for allergic rhinitis in a resource-poor environment, because the diagnosis and treatment of allergy can be very expensive, involving very technical tests, but we'd like to see what we can do. It's good to talk about the anatomy of the nose, some measure of the physiology of the nose. There are two cavities to the nose, the right and the left, with the nasal septum separating one from the other. We are seeing the lateral wall of the nose. We have the inferior turbinate, the middle turbinate, the superior turbinate. Very important components of the nasal system is the paranasal sinuses. In the cheek, we have the maxillary sinuses. In between the eye, we have between the eye and the nose, we have the ethmoidal sinuses. In the forehead, we have the frontal sinuses. And then behind the nose, we have the paranasal sinuses. Many of the diseases of the nose are not necessarily restricted to the nose. So that's why sometimes when you talk about rhinitis, some authorities want you to refer to it as rhinosinusitis. They have the same epithelium, and generally the diseases, they affect one another. So we have moved from rhinitis to sinusitis, but what is common today is to refer to, well, they allow environment to get into the lungs. And while the air is doing that, it moistens and warms the air. It also acts as a filter. Well, least important of these, we have the hair in the vestibule of the nose, which can filter some very coarse particles. But particularly, we have the mucus. When these particles along the mucosa, it is sticky, so it doesn't go in with the air, it's swallowed. The nose, there is also olfactory function of the nose. It is usually, the olfactory epithelium is located in the superior portion of the nasal mucosa. Also, as a matter of speech, it affords some resonance. It's a resonating chamber. The nasal cavity, along with the paranasal sinuses, helps us to give appropriate speech. We did do a study in Ilorin about the management and outcome of rhinosinusitis in Nigeria. One thing that is clear is that sinusitis is one of the most frequent otorhinolaryngological diseases encountered in everyday practice all over the world. And many times they will have seen the pharmacist, they will have seen the general practitioner, even the obs and gynae, some of them will come across them in their practice. So nearly everybody comes across rhinosinusitis in their practice. Allergic rhinitis affects the quality of life, the productivity, and the finances of patients. So generally, we have, by way of classification, we have the allergic rhinitis, we have the infective rhinosinusitis, and we have a group that is called non-allergic, non-infective, that generally we refer to as vasomotor rhinitis. So if we pick the allergic rhinitis, it is a chronic clinical condition, usually due to allergens that Dr. Erere has already described. The symptoms of allergic rhinitis include inflammation of the nose, itchiness of the nose, runny nose. Initially, it starts with watery discharge, but when infection sets in, the discharge can become thick, and then it can become colored. It could be whitish, yellowish, or whatever. Also, it affects the eye. There is redness in the eye. There is watering of the eye. There is itching of the eye. Also, the throat is affected. You have some of them have some measure of sore throat, itchiness of the throat, a burning sensation. That's this put together. They are the common causes of allergic rhinitis. We can divide them into two. There is the allergic rhinitis, intermittent, so it comes and then goes. And usually those ones are due to pollens from grasses, from weeds, from trees. Whereas the persistent, or what we call the perennial allergic rhinitis, the causes include house dust mites, mold and fungus spores, cockroaches, animal and food, or chemicals. We need to understand the cells. But as soon as such a contact is made, antibodies in the form of immunoglobulin E, they are released. By the time contraction of the respiratory airways. So you have some measure of bronchial constriction. And that is also what is responsible for the itchiness, that is the release of histamines and the rashes. Well, just as it has been mentioned to us, COVID-19, it has some similarities with some of the allergic rhinitis symptoms. And this sometimes can make physicians or other health workers have a full personal protective equipment. This has been to the advantage of some of these patients, sometimes even team. But in allergic rhinitis, some of the major similarities with COVID-19 include dry cough, sneezing, watery rhinorrhea. But we would like to say that not every one of such patients is COVID-19, especially for the doctor who has been taking care of them. The history dates back quite a distance. After taking our history, usually we like to examine the patients. There is the general examination. Part of the first things that you see in a patient with allergic rhinitis is what we call allergic salute. Usually, so they rub their nose very frequently, sometimes very vigorously. And for them, the tip of the nose may become swollen. And if it is in the light complexion people, it is hyperemic. But in the dark complexion individuals, we only see it as thickened. It is larger than usual. After some time, it will regress. But there is also an area of hyperemia at the junction of the cartilaginous and the bony component of the nose. That is as a result of that. So this is a very important sign that tells us what individual has allergy. When we do a rhinoscopy, looking into the nose, usually in a patient with allergy, with allergic rhinitis, the nasal mucosa appears pale or bluish. It is buggy, there is a swelling. You might find a watery discharge. Allergy, they may polyps. Particularly for the general practitioner, the illustrated diagram. In this diagram, for example, you have the inferior turbinate, you have the middle turbinate, you have the nasal septum, and in between them, you can see a nasal polyp. If you look critically at this, you will see that the color of the polyp is pale. It's slightly different from the color of the turbinates and the septum. So this is the way the polyp usually will present. Now with endoscopy, very easily we can get to know them. Then I have here the picture of a neglected nasal polyp. Probably started as a allergic rhinitis, but it's not been well growing externally. Because of frequent rubbing, because of frequent infection, you will see that the polyp is no longer pale, it's no longer gray. You know, there has been some inflammation, there has been some changes in color, but this is nasal polyp. Sometimes also, when we deal with allergic fungal sinusitis, we do rhinoscopy, whether directly or through endoscopy. We can see that in the nose of such patients, you have plenty of cross. The colors vary from brown, yellowish, greenish, whatever it is, but these are congregates of fungus. The color will depend where you have the symptoms of allergic rhinitis and you have peripheral eosinophilia, it helps you. Another thing we usually do where resources are low, we do a nasal smear. We are looking for eosinophils, large clumps of eosinophil. When you have a large quantity of eosinophilia in the nasal smear, we regard it as tending towards allergic rhinitis. But we must bear in mind that we also have non-allergic rhinitis, such as Neris, that can also be associated with eosinophils in nasal smear. When allergic rhinitis has going on is a complication of the allergy. So when the polyps have been thoroughly removed, this patient will still require to continue on his anti-allergic treatment. Well, this CT scan is an example of what we find in fungal sinusitis. Somehow it is more destructive than other forms of sinusitis. We did a study and its contributive factors in allergic rhinitis in Nigeria. We were quality of life is, health-related quality of life. And in this study, we observed that allergic rhinitis had appreciable impact on the health-related quality of life of the participants. We also observed that the residential area of these participants, as well as the duration of their symptoms, they were major contributory factors to the poor general health that they had. In an effort to domesticate the management of allergic rhinitis in our environment, particularly in areas where resources are poor, we did a study on symptom score for allergic rhinitis. The symptom score for allergic rhinitis asks a few questions from patients who suffer this ailment. It is so easy that the general practitioner can do it. The other health workers can do it. House officers, nearly anybody can make a diagnosis of allergic rhinitis. There are 16 scores, so we use a cutoff score of 7. was found to be optimally discriminatory. It is already otolaryngologists would like to give it for much less than 10 days because individuals can get used to the benefit they derive from it and they abuse it, they continue to use it. We like to warn that it has the capacity to cause rhinitis medicamentosa, which is another form of treatment. Because after some time, the nose can get used to it and then it will no longer be useful. We also have oral and local non-sedative H1 blocker. All these three are available to all forms of allergies, but we reserve the local chromones and the intranasal steroids for moderate to severe intermittent allergic rhinitis, mild persistent rhinitis, as well as the moderate severe to severe persistent allergic rhinitis. Again, some of these images I took from Google Images. I thank you most sincerely for your attention. Thank you.
Thank you very much, Prof. Ologe,
Yes.
for that very brilliant presentation and very, very detailed and lucid presentation. Obviously, you've had to do quite a lot of work on this condition. So we thank you very much. I think we should give the two speakers a round of applause. Now they have spoken very brilliantly on the topics that have been given to them. And all what is left for me to do is just to give a brief summary of what they have discussed while we are keeping tag of the questions that are being sent into the question and answer box of the platform. Dr. Erere talked about allergic manifestations and clinical management of urticaria in a pandemic situation. He clearly gave us our learning objectives, which is to help us understand the clinical manifestations of urticaria. She highlighted the recent updates in the management and gave us an insight into skin allergy and COVID-19 link. She started by describing to us or defining for us what the primary care physicians, who they are. And it's quite interesting that she included Google as one of the primary care physicians. Some of you may wonder, you can read up quite a lot of information. So that is went on to go to terms with urticaria. However, our
difficult to differentiate. What we are saying is we should not, because of fear of COVID-19, stop treating our patients with allergy. When you are in such dilemma for a patient you do not know before, you have not managed before, you use a PPE and then treat the patient. So the way to differentiate is to do COVID-19 test, and if the patient is positive, then you pick him up. If it's negative, then it's that. Thank you very much. I think, okay, you meant nasal douching. That is correct. So that is what we do. What I described is what we meant by nasal douching. It's important you do it with nasal, normal saline. There are specialized bottles for it. It gauges how much comes in and how much goes out. But where you don't have the specialized bottle, you can use syringe. But when you are applying it, you remember to remove the needle. You push the normal saline through the syringe without the needle. Thank you very much.
Okay, thank you, Professor Ologe. I think you have answered most of your own questions. I think there's a question for the company, Getz Pharma. Yeah, okay, there's a question for Professor Ologe. I don't think you looked at that. It says, what is the best approach to management of allergic rhinitis coexisting with vasomotor rhinitis? That was from Dr. Kunle George, a dermatologist.
Okay, the best approach for allergic rhinitis is to identify the allergen and avoid the allergen. That is the best approach.
Okay, it says the one allergic rhinitis that is coexisting with vasomotor rhinitis.
Okay, well, for vasomotor rhinitis, if it is coexisting, you treat the and you meant for motor rhinitis. Generally, we use drugs like Belagal, Himanal, and such medications. They tend to help to manage the autonomic imbalance, because vasomotor rhinitis is more of autonomic imbalance rather than allergen antibody reaction. Thank you, sir.
Very brilliant. Thank you very much, Professor Ologe. Yes. I think I'll let Kehinde answer the one from concerning the company.
Okay, thank you.
Yes.
Thank you so much, Prof. If you can see my screen, we can see that presently we are playing in about six portfolios, 6 segments: cardiovascular, diabetes, gastrohepatology, anti-infectives, anti-allergy, and anti-malaria. So, like I mentioned earlier, we are rapidly expanding because there is a valid need for us to expand. So because of that, from our hand, we are looking at expanding towards the immunology portfolio, which also would have omalizumab or similar products as necessary. So our commitment is still not changing. What I can assure you is that we are on a mission to make sure that every Nigerian, irrespective of their social status, irrespective of the disease conditions they have access to quality medications. So I'll just enjoy you to keep your fingers crossed, come on the journey with us, and we hope to partner more with you to the benefits of the patients in the coming weeks and months. Thank you so much, Prof.
Okay, thank you very much, Kehinde. There's a question from Dr. Perpetua, who has asked whether she noted that some patients do not respond to antihistamines. And she's wondering whether your company, whether Getz Pharma has any plans of bringing omalizumab into the country for use.
Thank you very much, Prof. What we are still saying is that Getz Pharma has a lot of ranges, and it is our mission to actually make sure that everybody, at least everybody actually have access to healthcare. And as such, we are bringing something similar to omalizumab very soon, and those things are already in process. Thank you very much.
Oh, okay, that's very good. That's very, very valid information. We are very, very grateful for that. Dr. Perpetua, I think that has, addressed your anxiety. So Getz Pharma is there to assist us all. There's also the other question from Dr. Okonkwo from Erere, asking whether fexofenamine is available in syrups for children. Maybe Kende will answer that.
Okay, so presently in Nigeria, we do not have fexofenadine registered for children or available for children. It's one of the, we have the FexZ 60 milligram that can be also used in children by splitting the FexZ 150 milligram. So when you have the need to use a fexofenadine in children, for now you can use the FexZ 60 milligram. But I can assure you that we have already started the process of registering FexZ 60 milligram for the use of benefits of pediatrics patients and every other person that may have to step down to FexZ 60 milligram. Thank you very much, sir.
Okay. All right. Okay. Dr. Erere has some questions, of some one or two unanswered questions.
Thank you, Prof. I have a question from Dr. Okara. Thank you. What tests outside stool and full blood counts would you recommend for chronic urticaria in older children, especially when the patient is demanding to have a diagnostic test? Yes, I can understand that dilemma, because sometimes we have patients who say, what else can you do? Can't you do this? Can't you do this? Again, I want to just re-emphasize that when you are talking management, you have to start always from the history. Your patients are going to be more appreciative of your effort when you go step by step. So of course, after taking your history to look for possible triggers or eliciting factors, remember I put that slide up that in no particular order, you want to run the infectious profiles, so stool for H. pylori, like you rightly said, and the auto antibody. So we do a thyroid function test. Now remember, if you say older children, thyroid function tests, so we're looking for the thyroid auto antibodies, like the similarity between type 1 DM and Hashimoto's or Graves, as the case may be, or other autoimmune diseases. That can actually explain a bit of chronic idiopathic urticaria. Well, it will be idiopathic when you check and they're fine. That's when we will now say idiopathic. What else can you do? You can also do, so when you talk about the allergens, especially food, nowadays our parents always talk about is when he eats this food that this happens, is when they eat this food that this happens. And of course you say, okay, avoid this diet and gradually reintroduce and see whether those same symptoms come up. So that allergen avoidance is also very key. And that is something that they take particular, they are participating in it. You are going gradually, you are having a plan to check immunoglobulins, RAS, you can do RAS, you can do the also serum testing, which to be fair, for chronic idiopathic urticaria has not really diagnostic tests. So you do ASST. However, you know that there are patients that have positive ASST, but meanwhile they don't even have urticaria. So you have that balance, but these are diagnostic tests in a manner of speaking because they're coming from you. And then, of course, you can think about skin allergy tests, from the prick test to the So you have pre-test, you can have patch test if necessary. You can actually now do the intradermal test where you look for particular antigen and you check them. And of course, you can think about RAS, the RAS panel, you look for the panel of allergens. So these are all supposedly diagnosis. I'm actually pleased that you put your diagnosis in parentheses to let us know that there is really no diagnostic test. It's a lot of things together. Just like I think Prof has already alluded to that even in AR. I hope that answers the question. Thank you.
Yeah, thank you very much. Dr. Erere has thrown a lot of light into those questions, and I think we've done justice to most of the questions. Now let us look at a few things relating to the overall theme of the Allergy Week, World Allergy Week. Allergy care does not stop with COVID-19. We all know the symptoms of COVID-19. Most of the early symptoms tend to be the symptoms of the flu. And we know what the symptoms of allergies are, mainly sneezing, watery running nose. When it's associated with asthma, there may be difficulty with breathing, which is also one of the symptoms of COVID-19, and then itching on the skin. Now, how are these related? Now, one of the posers I like to put across is patients who have pre-existing allergic rhinitis, as we are entering the rainy season, will tend to have more symptoms. And one of their key symptoms will be paroxysmal sneezing, where they sneeze a lot. Now, we know that COVID-19 is transmitted by droplet infection. So when they sneeze in paroxysms, they are sneezing inside the house, and so they are putting the people in the house at risk, or they are sneezing outside. How does that link up? So the issue is, if a patient who is a known patient with allergic rhinitis has contacted the COVID-19 disease early, when he has not started manifesting the full symptoms, and is manifesting the symptoms of allergy, is he at a greater risk of transmitting the disease? This is the area I want us to look at. The other thing is that in terms of the skin issues of allergy, itching is a major part of it. And so the itching, we are also told as part of the preventive measures, not to touch our nose, not to touch our face. And if the place is itching you, so what do? So the point I'm trying to make is that some of the symptoms of allergic rhinitis can either help to spread COVID-19 more easily if the individual contacts COVID-19. And then on the other hand, they are also at risk of spreading. So we need to provide some solutions to people who have allergy when they develop symptoms. I want to know what your idea or what your thinkings are. Maybe I'll start with Dr. Erere.
Thank you, Prof. Thank you very much for insights. You brought that out quite subtly, very clearly. So the points to itching, like you rightly said, they say don't touch your face, don't touch your face. Sometimes even before the itching, the mask that they're wearing will cause some allergic reaction. Yes. And then the natural thing, first of all, is to even remove your mask to sneeze properly. So there's the point. Now, if you supposedly asymptomatic COVID infection already, and you sneeze that, effective thing, you have pushed it out into the air. Again, this actually bears the importance of everybody mask up, so that the person who does have the allergy, whether or not they have asymptomatic COVID, you will prevent the next person from getting it. So that's one, itching. Now, itching, we have said as much as possible, keep your hands clean, wash your hands. You are scratching, yes, you are scratching. Urticaria is extremely itchy, and most of this atopic dermatitis is itchy. So after the scratch, the idea is when you finish scratching, go and wash your hands, or you think you are not infected. But if you have that, what is allowing your recurrent arthritis is identifiable, then you avoid it. I think that is the most important thing, avoidance of that. Now, this really comes to mind because of sanitizers, soaps, sprays, bleach. A lot of people are having some hand dermatitis, which will cause them to. You know why? People are not being told to moisturize their skin after using any of all of these things that prevent it. If you moisturize, you will reduce your frequency, because most of these things have alcohol and they're drying agents. So once they take away your natural moisturizing factor, you're losing water, you're going to scratch. And there's no amount of that you will scratch, you will touch your face. Because like Professor Ologe said, the whole, it's still the same hand. And you touch that mask that you've already worn, and you put it aside and sneeze and put it back again. The rest of your body is exposed. But I think what I want to say is, if we remember that just the idea of a viral infection can even predispose patients to a bit more immunoglobulin, IgE exacerbation. So let's assume you had the virus and you were not in the flare. The viral infection itself can make you flare up. So it is most imperative to control the flares. I think that's where I want to go. Most imperative to control the exacerbation of the flares. However means, and there was that slide I said about treat as much as possible, but as little as necessary. That is emphasis. So the treatment, remember again, is avoidance. So by now, you probably know your allergy, so that you are moving to this rainy season now, the change from dry to raining problems, you are beginning to have a flare. You avoid it and see if you can control your exposure to that environment. So if you cannot remove the environment, remove yourself from the environment. Then use what will work for you. Increase your doses as necessary. This is not acute allergies I'm talking about, this is not the chronic. For the acute ones, it's very, very simple, because you will know, you can actually sense it. That sneezing, before the sneezing comes, you know that, okay, this is about to happen. If you have moved into a new environment, find a way to quickly get out from there. Stay home. Where are you going to? Everybody stay home. If your house is the allergen, then move homes. I don't know what else to say to you, but as much as possible, I think that if we have a fair idea of what is our predisposition, what is triggering it, stay away from it. Use your anti-histamine. Use that histaminogenic response as much as possible. And hopefully with time, you get better. We might not need to get to omalizumab or azathioprine as necessary. Prof, does that help?
Yes.
Thank you.
Okay, thank you very much, Dr. Erere. I think let's get this perspective from Prof. Ologe on the issues raised.
Well, I think the only comment I want to make about it is somebody with allergic rhinitis is fighting two diseases together, the COVID-19 and then the allergic rhinitis, which that means is likely to potentiate his capacity to share the problem. Yes. That is the way I look at it. So two people, one person with allergic rhinitis associated with it, and the other person without allergic rhinitis. The one with allergic rhinitis is probably more dangerous.
Yes, definitely. So, yes, thank you very much. That is the point we want to raise, that those at the asymptomatic phase of COVID-19, if they have allergy, they are prone to spread it more rapidly to a wider group of people than those without allergy, because of that sneezing, the runny nose, and the itching. They can touch many things and itch their body and touch many parts of their body. Now, so from there, what do we then recommend? I think we should be looking at the fact that all those who know that they have allergy have been diagnosed to have allergy or atopy as a whole should be take more precaution during this period. Even the face mask they are wearing, they should look at it properly and see whether they are reacting to it or not. And also they should be more precautious in terms of going out and then, so that they should stay more at home. And if they know that they have been using their antihistamines and co, which has been helping them, when they start noticing the symptoms, they should go back to it first. And then if it persists without that, then they should seek attention of a physician who will then address the matter more holistically. I think that is my own take on it. I do not know whether any of our participants elsewhere who is on the platform has any specific questions or comments apart from the ones that we have taken. Well, somebody has put here, can we have the prices of these products? I think the company will share the prices on their YouTube and you'll be able to look at it. Dr. Okay, so if there's no other comments coming in, maybe I should then invite Dr. Funshaw Lauren Toba, the business manager of Getz Pharma, to come and give us a closing remark. Dr. Funshaw Lauren Toba, you are welcome.
Thank you very much. It is a humble pleasure actually to say thank you to at least the crop of professors that actually anchoring today's program. I want to say a big thank you to Dr. Erere. I think she was the only lady in that panel. And I think she was actually at a point in time, she was asking for more affirmative. But since the female went for, we have given them 35% affirmative, but I think maybe currently they are asking for 50% or 90% or 100% affirmative. Dr. Erere, I want to say thank you very much for such beautiful presentation. And it is our hope that when else we call you, you can double for the number of females that you can actually stand for. I want to say thank you very much for your presentation. My also thanks also go to Professor Ologe. So it was so distant away, it wasn't a barrier. We want to appreciate your contribution. We want to say thank you very much for so much fluidity and eloquent in actually cascading those information to its lowest level. We say thank you very much. And my sincere thanks also go to our professor, the moderator of today's event, Professor Clement, who is actually more than 34 years clinical experience. And I learned that more than 80 published articles or journals have been done in different forums. Prof, I want to say we thank you very much for this thing. However, on that note, I would like to thank even our audience that actually make our time to join this webinar. We want to thank you for your time, and we hope that at least these are discussions today, and this event, we are actually going to better our clinical practice. We want to say thank you on behalf of Getz Pharma. We just want to say thank you very much for this webinar program. It is a pleasure.
Thank you, Dr. Funshaw. I think Dr. Erere was not the only female. There is Abigail Ojo, even though she refused to show her face, but she's She's, we see her. One of the product managers, yes. Okay. So, thank you very much. I think the Kinde will bring everything to a close now. Yeah. So, on behalf of Getz Pharma, I want to thank everybody, all the participants, and all the speakers, Prof. Ologe and Dr. Erere. You have done very beautifully well. You have given very excellent presentations. Thank you. Okay, Salisu. Okay, yes, it's flashing. Yes, 0803. 0803. Yeah, 805. 33 90. Yeah.
Hello. We also want to use the opportunity to thank ORLSON for the collaboration. Even in spite of dermatologists, please, we say thank you very much for your time.
Okay, yeah. Okay, yes. Yeah. Okay, yes. We'd like to thank Professor A.D. Salisu and Professor Aliu Kodia.
Yes.
Professor Salisu is the president of ORLSON, and Professor Aliu Kodia is the secretary of ORS Society of Nigeria. We'd like to thank them for the great job that they are doing for the society, and we say kudos to them. Yeah.
Thank you very much, sir. We appreciate you so much.
Okay. Yeah, thank you, Dr. Professor Kodia.
Yes, sir. Yes, sir.
Welcome. Yeah.
One of the presidents of ORLSON.
Yeah, I think he's not. The secretary is there. Okay, he's on. Okay,
No, the president is on. Okay. Just to say.